to cranial nerve 8, which then goes to the thalamus, and then finally the temporal bone, or the temporal lobe, which is going to sense what the heck you just heard. Is that you just heard something? We know that, but is it a bell ringing or is it a dog barking? The temporal lobe is going to interpret what you just heard. Okay? So, now, the best way I can explain this, here's the coiled area. You ever go to a birthday party when you were a kid and you have those party favors? That kind of, you know what I'm talking about, right? All right? So it's all coiled up. Now, if I show you the dissection of this all coiled up, I get really messed up with understanding it, the way all these words I just showed you. So the best way I could do it is think of this kind of thing, but it's straight now. And when it's straight, it makes more sense. So this is a straightened cochlea. Normally it's coiled up, but it gets really confusing. But do you understand it now? I mean, can you visualize it now? It's straight. All right, now, this is what's going to happen here. You have low frequencies, high frequencies of sound coming into your ear. There's your tympanic membrane. The vibration is going to be passed on to, like a baton in a relay race, goes to each one of the bones, and the stapes is going to transmit that vibration to the oval window, and now you have it going through this area here. Now, this is where the words come in, okay? This area here is a scala vestibuli, and it's going to contain perilymph. The blue stuff is the water, the fluid, okay? That vibration is going to go like this. If it's high frequency, it kind of enters this is what we call the vestibule membrane, that dark brown line over here, and underneath that is going to be the endolymph. This whitish area here is the cochlear duct that contains endolymph. See how it gets a little confusing? You can imagine if it was coiled up. Oh, bad. So again, scala vestibuli with perilymph, cochlear duct with endolymph, separated by this vestibular membrane. Okay, that's so far? Okay. This blue stuff is still perilymph, but when it gets down underneath here, this is the scala vestibuli up here. This is the scala tympani. It's connected. Make sense so far? Now, this is what happens. Oh, and then let me show you over here. You're also going to have the tectoral membrane over here that's going to separate the cochlear duct. And you see these little, I don't know if you can see it, but they look like little hairs, these little lines coming up. See this yellow area here? That's the organ of Corti that has these little hair-like endings that do connect in a way to the cranial nerve 8. So look what's going to happen here. High frequency sounds get passed into here, and they actually will pass through the vestibule membrane quite early. They'll actually enter over someplace in here. And when it does, it's going to hit these nerve endings closer over here. So that sends a message. They're high-pitched noises. We have an idea what that is. Or your brain figures out what's going on. Low frequency goes a little bit further out here. And when these hair-like endings sense that, we know it's low. So that's why we can deal with different pitches. For instance, if a dog barks, another dog barks, woof, woof, you can have an idea of which one is the small dog and which one is the big dog just by experience, by the frequency, the high pitch or the low pitch. Does that make sense? All right, that's what your temporal lobe is doing. All right, now the vibrations there's still going to be vibrations in here. It's still going to be in this area here. And if you have too much vibrations in here, another sound that comes in, it's going to mess up things. and you won't understand what you're hearing. So that vibration, that pressure has to leave that area. So it'll continue this way and go out the round window back into your middle ear, but it'll escape here and it won't interfere with the sounds that are going up here.
Sound waves strike the tympanic membrane and cause it to vibrate. Vibration of the tympanic membrane causes the three bones of the middle ear to vibrate. The footplate of the stapes vibrates in the oval window. Vibration of the footplate causes the perilymph in the scala vestibuli to vibrate, which in turn causes displacement of the basilar membrane. Short wavelengths from high-pitched sounds cause displacement of the basilar membrane near the oval window. This movement is detected by hair cells of the spiral organ, which are not visible in the animation. Long wavelengths from low-pitched sounds cause displacement of the basilar membrane far from the oval window. Again, this movement is detected by hair cells of the spiral organ, which are not visible in the animation. When the vibrations reach the perilymph in the scala tympani, they travel to the round window where they are dampened.
All right, but you all understand this from the video, my pictures, and like I said, the words are there. Just okay. All right, so hearing, just an overview again. From the external ear, it goes to the external auditory canal, to the tympanic membrane, got the middle ear with its bones, through the oval window to the inner ear, vestibule, to the cochlea, to the organ of Corti, and then you got the auditory nerve. So it's an overview. You know now more in detail, but an overview of that. And I won't expect you to know where the synapses are over here. Just understand it goes on over here. It goes into the thalamus and it goes to the temporal lobe, which you've learned from before. Okay. Decibels is a unit of sound or a measure of sound. Normal breathing is about 10 decibels, but when you get higher up here, like a vacuum cleaner is about 70. When you're getting to about 80 decibels, there's issues there. It can damage the ear. So our biggest, well, one of our issues is kids making their iPods go up all the way. With that intense sound that's happening in the ear, I mean, you're looking at a rock band 4 feet away is already at about 95 decibels. A jet fighter taking off, a jet plane taking off, you're looking at about 130. That's why when you look at people who are doing this, you know, that kind of thing, and you know, whatever they're doing, they got the earmuffs on them because they know they'll blow their eardrums and cause damage over there. But our concern with this, the earphones at the highest volume is at 110. So what we're predicting is a lot of different things happening as we're getting older. Smartphones are making smart people smarter, but they're making dumb people dumber. I mean, don't blow it up all the way. You are going to be, we're going to start seeing a lot of things happen that we usually don't see until a very early or very late stage in life. We're going to see it much earlier, like deafness. You know, instead of seeing the usual deafness as we get older and elderly, we might be seeing it, let's say, 50 years old or 45 years old because kids are doing this kind of thing. We're already seeing that there's a new tendinitis in people's thumbs over here because people are talking or they're using the, you know, your PlayStation or Xbox kind of games. Our thumbs were not made to do this. Does that make sense? Now, over 1,000 years or 1,500 years, perhaps we will get a new tendon over here through evolution, but it's not going to happen during our time. So our thumbs were not made to talk, so to say. So we're seeing kids with new tendinitis. We're probably going to see a lot more hunchback also going with kids, all right? Not kids, but as they get older. What's happening here is that our muscles over here are holding up our head. Remember, our head is about 7 pounds, all right? You put a 7-pound brick over here, our muscles are not able to hold a brick for a very long time. It's going to start going this way. At this point, our head is not holding, our muscles in our neck are not holding our head really. All right? I mean, it's doing somewhat, but they're small muscles. But what'll happen is, when you're texting, you're doing this. So what's happening here is that these muscles need to hold this head that's now dangling this way. Does that make sense? And the muscles back here will gradually get thicker and bigger. So now the kids are going to start looking like this, because they got to hold up a head like that. All right? So they got to, the best way to be texting, what's the best way to text? Like this. Well, who does that? Well, I can't text like that. Then don't text. What do you want me to tell you? All right? You're going to get a hunchback over here. Kids don't understand it. Oh, whatever, you know. Kids are, you know, they feel vulnerable. They can do anything, right? Oh, don't worry about my knees. I'll just play football and stuff. But they pay for it later on. They don't think that way. So here as adults, we got to talk to them. But of course, you sound like your parents, you know, telling you to do certain things and don't do this and that. But who are we, right? We're just the elderly trying to teach our children what to do. But that's what's going to happen. You'll see it. These things happen. You know, I'm not saying don't listen to your iPod. I'm just saying don't blast it. You know. So anyway, but that's what a decibel is. You don't have to worry about the numbers of this. Just understand what a decibel is and our concern with children. Okay. So now let's talk about sense of equilibrium. Okay. Static equilibrium. All right, static equilibrium's perception of the head is, and the body is stationary. There's no movement. All right, you sense that you're not moving. Okay, we have dynamic equilibrium, and this is where you sense that the body is moving. But we have two forms of this. Okay, we have linear acceleration, and this is where you're going this way, or we're going like in an elevator up and down. So that's what we call linear acceleration, and that's what it senses. We also have angular or rotational acceleration, because if you keep your eyes closed and you're in the passenger's seat, you could sense if the driver is moving left or right. That's what this is over here, okay? And there's different ways that we got to explain this. So static equilibrium, you know that you're not moving. Dynamic, you know that you are moving, but there's linear, which is going a straight line this way, that way, up and down. Angular is that you're turning. Okay? So we got a few other words here. There's two balloon-like chambers in this area, and they are called otolith organs. Lith means what? Stone. Okay? Nephrolithiasis is a kidney stone. Cholelithiasis is gallstones. So it's otolith. Oto means ear, lith means stones. So yes, you do have stones in your head. Some people may have a little bit more, but okay. But there are stones in your head. Okay? This is going to detect static equilibrium, and it will detect linear acceleration, not angular, linear. Okay? And these are the two organs that have a little stone in there. There's fluid in there, and the stone, if it's not moving, it's sensing static. But if it's moving straight, up and down, it moves a certain way, and the fluid moves with it. Okay? So this is what's happening here. This is the vestibule, and inside we'll have the two organs, the utricle and the sacula, which are the otolith organs. They're going to be located right here. Okay? We already dealt with the cochlea. I'm not going to talk more about that. But we got to talk about this portion here. There's also what we're going to talk about too is the maculae, which is over in the utricle and sacula. So inside the maculae, they're found both in both of the otolith organs. We have something called the macula saculi and the macula utriculi. This one lies vertical on the wall in the sacula, and this one is going to lie horizontal on the floor of the utricle. These are the ones that are going to sense static equilibrium and linear equilibrium. These hair-like receptors are connected to cranial nerve 8 as much as hearing is. So it takes care of, cranial nerve 8 does take care of hearing, but it's also going to be taking care of balance and equilibrium. The 3 semicircular canals detect rotational acceleration, and this will contain fluid called endolymph in here also. Now the best way I can explain how these semicircular canals are is if you look at the corner of the room. There's one semicircular canal that's going to be the floor. There's one against that wall over there, and then there's one over here. Does that make sense? That's how it's organized. Now, what's going to happen here, see it's like in the corner of the room, okay? What's going to happen here is that there's something called, well, these hair-like nerve endings are here also, and it's called the crista ampullaris, and they're located at the openings of these semicircular canals. At the ends of these hair-like projections, all right, these crista ampullaris, there's like this gelatinous covering around it, and it's called a cupola. And there's fluid in there. So let me show you what this is. All right, here's those hair-like endings. There's endolymph in here, and the endings over here, the nerve endings end here, but then there's this gelatinous cupola. Okay? What happens here is that, and I'm not too sure why we put this over here as opposed to just free endings, but as the fluid moves over here, it's going to move this cupola, and it's going to move all these hair-like projections all at the same time in one way. So let me show you what's going on. Let's put this all together here. You got these semicircular canals. One going this way, one going over here, and one going over here. If I'm rolling this way, spinning this way, the fluid is going to be moving over here in a certain rate. That fluid will be moving in a certain rate, but maybe this one over here is not going to move at all. So this information is then going to be, since the fluid is moving the cupola, it's then going to send the nerve endings, the action potential from those nerve endings to your brain to figure out, oh, the fluid is moving in that direction and this direction, so you must be going that direction, your body. Does that make sense? It's the combination of that. How the brain does that, I don't know. But it's those semicircular canals are strategically placed so that your brain can figure out which way you're going. Are you doing a somersault? Are you doing moving to the right, to the left? Because of the way that it's moving. Does that make sense? You can visualize it. Now, here's where it comes handy. Why is it that if I spin around and 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 then I stop, why does it feel like I'm still spinning? And I do. What's happening?
The cupola is still laying down?
Yeah, the fluid is still moving. Even though I stopped, the fluid is still moving and it's pressing that cupola to the side still. So it feels like I'm still spinning, but I'm not. Does that make sense? Until that fluid stops. Now I feel perfectly fine. All right? That's what goes on with this. Okay? So right now, stationary, it's not moving at all. But when you turn your head, it moves a little bit. You turn a lot, it doesn't move a lot. Someone did a hard left-hand turn or did a soft right-hand turn. You can sense that even if your eyes are closed. Okay? Does that make sense? It's kind of interesting, right? Okay? And this goes the equilibrium. Again, I'm not going to ask you where it goes. I put this here to be complete, but a lot of students are always curious, like, where does it go, you know? Like George. Okay? So if you think about it, why do you get motion sickness? Ooh. Well, this is a complicated thing, but I'll make it very simplistic for you. It's a confusion of the brain of three different things. your skeletal muscles, your eyes, and now we're learning about the ears. So look at this. I'm in the passenger seat, and we're going 60 miles per hour, okay? Going straight on Route 80. I'm sitting down. My skeletal muscles, do they sense that my body is moving? If I'm sitting down, is my body moving? No, my body's not moving. The car's going 60 miles per hour, I'm going 60 miles per hour. All right, if I'm going on a train that's going 60 miles per hour, and I jump up and land, am I going to land in the same spot, or am I going to land a few feet behind because the train is going faster than me? That's an interesting thing, right? The train is going 60 miles per hour, I'm going 60 miles per hour. If the train stops, am I going forward still? Yeah, because I'm still going 60 miles per hour. Okay? So if I jump on a train, in a train, I'm going to land on the same spot because I'm going as fast as the train. You don't think that, but that's what's happening. So, if I'm sitting down in the passenger seat, are my skeletal muscles sensing that I am moving or not? No, because I'm going with the same speed as the car. So to me, I could be sitting in a car that's not moving, or in a car that is moving. My skeletal muscles don't sense that I'm moving. Okay? What about the fluid in my ear? Does that sense that I'm moving? I'm going straight. Not really. I mean, the fluid is not moving, right? Think about it. I'm sitting down. If it's going, that means even the liquid in my ears are going 60 miles per hour. So therefore, the cupola isn't moving. It's going 60 miles per hour. Does that make sense? So my skeletal muscles and my inner ear don't sense that I'm moving. My eyes, I'm looking out the windows. Do my eyes sense I'm moving? Yeah. That does work. So what's happening here is that motion sickness is a confusion of these three things, because one of them doesn't fit in the picture. One of them is saying you're not doing what the other two are doing. So that sends, in certain people, that sends a message to the vomiting center in your medulla and gets you nauseous. Why? We don't know. That's why some people get motion sickness. They're a little bit more sensitive than other people. That's what's happening. Now, let me ask you this. If you're one getting motion sickness, what can you do that's a non-medicinal, non-surgical thing that you could try to see if it eliminates your dizziness? What can you do? Close your eyes. Eliminate that one. And see if that works. In most cases, it does. I got to close my eyes because that's what happens. Now, what about, let's talk about a roller coaster ride. Still talking about the three things: skeletal muscles, eyes, and ears. Okay? Now, I'm strapped up in this roller coaster, and I'm going all over. What are my eyes telling me? I'm moving or not? No, you're moving. What about the fluid in my ears? Is that moving or not? You're not moving. What about me being strapped in here with a skeletal muscle? I'm not moving. Does that make sense? I guess the way you can actually eliminate it is like get your hand and go, oh, look at me, you know, and move that. But that won't work because you got to move your whole body, so to say. And that'd be kind of ridiculous to, to allow you. All right? But does that make sense about motion sickness? It's a confusing thing of your body doing those three things. All right? So skeletal muscle, ears, and eyes. Okay? Not too bad. Interesting stuff. Yeah.
How do you explain vertigo?
Oh, we'll get into that.
Okay.
Because there's a difference between dizziness and vertigo. Okay? All right. So here's some abnormal findings. I'm going to kind of breeze right through this because it's pretty self-explanatory. Infections in the ear can occur in any area. We have an infection in the external ear. We call it otitis. Oto means, or ot means ear. Itis means inflammation. So we got otitis externa, which is known as external or a swimmer's ear. Okay, you've heard of swimmer's ear before, right? All right, you get an ear infection here. The kids have to put antibiotics and put cotton in ears. Okay. Otitis media is the one we see a lot in children too. Okay, that's the one that's inflammation or infection in where the bones are. But we want to make sure we can clear that up here before it gets into the internal portion, because that's where your nerve is, and you don't want that to get affected. A foreign body in the ear, just a FYI kind of thing. Someone put a spot. Which, by the way, what is the most common? Kids. All right. First, 1, 2, maybe 3-year-olds. They're fascinating by all the holes in their bodies. All right, they are. What's the most common thing that the children like to put in their orifices?
Toys? A crayon.
No. You would think the obscure kind of things: crayons, toys, peanuts. Nah.
Their finger.
I mean, they do those. Their fingers, yeah. Well, yeah. No. Tissue paper, toilet paper is the most common thing. Not so interesting. One of the strange things that I had when I was working as a medical student, a kid put an aspirin in his nose, and I think he was allergic to aspirin. But our concern was that it would get absorbed because there's a lot of blood vessels in there. So luckily everything was okay, and the easiest way to get it out was, I learned this from the emergency room doctor. You know how to get it out? If it's in here, you close up this and ask the kid to blow, and it blows right out. But if it's a 2-year-old that doesn't know how to do that, I mean, just asking him to blow his nose, I mean, they're blowing out of the mouth kind of thing. They don't know how to follow directions. So, but anyway, yeah, tissue paper is the most common thing that we see in kids' ears. But don't get me wrong, they like to put everything in there. But that's the most common thing. This is just showing you otitis externa, if you want to see what a picture looks like. I'm not going to test you on any of this stuff. This is just FYI stuff. Otitis media, you can see over here that there's a lot of fluid. There's a tympanic membrane, but there's a lot of fluid behind there. All right. There's otitis media, there's a little opening over here. You've heard of this, the kids getting the tubes in their ears. What is that all about? It's not really a tube like you're thinking, like a tube. It's more like a grommet, so to say. I'll show you what that is. It's what we call a polyethylene tube. This is for kids that get recurrent ear infections. They always got an ear infection in the middle ear. So when you have 3 recurrent ear infections, means that you're having more than 3, I guess 3 consecutive times that you have it within a year. And because of that, they like to put a hole in the eardrum, but a surgical incision, which will heal nicely. You don't want to go to a rock concert and it blows it, because then it's all, jattered. The hole itself is hard to close up. But when you have a surgical incision, it kind of heals by itself very nicely. So they make a small incision in the eardrum, and they place a little grommet there, not really a tube, but a grommet, and allows the fluid to always drain out. So they make this little incision over here on the eardrum, okay, and then they put this little grommet there. See what I mean? It is a tube, but it's a very short tube called a grommet, and it fits in like that. So now if there's any fluid in here, it'll just drain out this way. And they leave it in there. It usually stays in for about 2 to 3 weeks, and then they kind of fall out by themselves. This grommet, it doesn't really show it here, but this outer end is much bigger, so it won't fall backwards. So it'll only fall forward. And I had them, I remember when I was lying on a pillow, I was in 2nd grade or something, and you saw this little black thing that was on my pillow. And they usually just fall out. So, all right, questions about that? That's what tubes in the ears are all about. Okay, so it just constantly keeps the drainage out there. This is one right there, you see it? You can see what it looks like if they're looking with an otoscope in there.
That doesn't affect the hearing?
No, it actually makes it better. Yeah, because it's only a temporary thing. It's draining out everything, but then this will close by itself. Once that comes out, it'll close nicely, and it's fine.
Can water go from the outer ear to the inner ear? Or is it like a one-way valve that only lets it out?
Well, we wouldn't do that. If there was fluid in the external ear, we wouldn't put this in here.
We'll say like getting a bath or something like that, and the head goes in the
Well,
water.
they'll put cotton in the ears.
Oh, okay.
Yeah, they'll put cotton in the ears. I remember doing that as a kid. They put cotton in the ears. They didn't want us to do swimming, but you can't tell a 2nd grader kid goes swimming in this pool.
Right.
You know what I'm saying? So what we did was we went swimming, but I couldn't dunk my head. that was a little compromise.
If a kid gets ear infections regularly, how many times do they normally have to like put those tubes in the ears?
I've only seen it a couple times. Then they got to look into something else. They got to figure out why is the kid getting it. Is it because of the anatomy is different? Maybe the eustachian tube is not bent in a certain way. So, but then they'll also probably put them on an antibiotic, a low dosage of an antibiotic for a whole year. You know, just so they, you know, it's a deterrent for bacteria to get into the ear. So they'll find other ways to do that. But to have them in there to do surgery, insurance companies won't enjoy that. Someone's paying for it. So, but there's no permanent ones that you do. Okay? Other questions? Okay? Deafness. There's two types of deafness. There's conductive deafness, and that means that there's some kind of impaired conduction of sound from the ear to the bones. All right? So you could have impacted wax in there, so you can't get the sound from the outside world into the middle ear. Okay? There could be a foreign body that's in there, obviously. Otosclerosis. For some reason, the stapes is not moving so well. And this is something that we go, you know, as we get older. A form of arthritis, so to say. It doesn't move as well. So therefore, you can't get it into the inner ear. Or perforation of the eardrum. If you have an eardrum that's going to perforate there, the sound that comes in from the external canal to the bones themselves, now the vibration has no pressure. You know what I'm saying? You can't equalize the pressure. So it's going to muffle the sound. Okay? That's conductive deafness. That's because there's something wrong with the sound coming from the outside world to the inside world. Then we have nerve deafness, and this is auditory nerve deafness. Something happened to the auditory nerve. All right, with an infection, maybe the child was born a certain way, whichever. But that's where this comes in. Okay, it could be congenital. Certain antibiotics can do that, and things like that. Okay, so there's nerve deafness and conductive deafness. Okay, other abnormal findings as we get older, we have something called presbycusis, which is basically old age hearing. It's going downhill. Okay. Meniere's disease is edema, which is excessive amount of fluid that is going into the semicircular canals, and this can actually cause some destruction. Okay. Tinnitus, which we were talking about, is this constant ear ringing, and has something to do with the nerves. It's just we're not too sure, but like we were talking about, it has something to do with the nerve endings, but it has something to do with the nerve itself. It's something to do with the nerve, okay, that's causing that. That can be due because of going to a loud area, or there's certain medications. Someone who's on medication called gentamicin, which is a type of antibiotic, or aspirin can actually cause tinnitus to occur. Okay, someone taking aspirin all the time, they could also be complaining about ear ringing. So that's where, you know, we're seeing doctors and nurse practitioners and physician assistants asking the right questions, figuring out what's going on here. Don't just look up what are the causes of tinnitus. Ask the right questions and say, well, what medications are you on? Aspirin. Oh, well, aspirin. Why don't we take you off aspirin? You're taking aspirin for what reason? Okay, well, why don't we use Motrin or Tylenol and see what that does? And then 4 weeks later, she comes back away, and it's being able to do that, right? Figuring out what's going on. Now, vertigo versus dizziness, two different things. Vertigo is the feeling that the room is spinning, but you are not. What I was doing with you earlier, okay, is spinning around like that and then stopping. And I'm saying I feel dizzy, but that's wrong. I'm feeling vertigo. Vertigo is the feeling the room is spinning, but not me. Okay? And it's really dealing with the semicircular canals, the fluid moving in there. Okay? Dizziness is that you are spinning, but the room is not. And this has something to do with the nerve being affected. The best way to understand what this is ask the person. Even if she or he comes in and says, I feel dizzy, don't take that as a grain of salt. That just opens up a can of worms for you to ask the right questions. And just ask her or him. Do you feel like you're staying still, but the room is spinning? Or do you feel like you're spinning, but the room is staying still? They'll be able to explain it to you and say, oh no, definitely the room is spinning. You spin around at home. And then sit down on the couch. I don't want you to be standing up and encouraging you to fall down on the table and hitting your head. But spin around and then just pause. You'll feel the room is spinning, not you. And that's what that is. Okay? In fact, vertigo, remember how I said there's otolymph organs in there? And there's a little stone in there that moves around. Well, in some people, what happens here is that there's an extra 2 or 3 or 10 pieces of calcium that get in that area too. Now you have 10 pieces of stones spinning around in there. That can also get them vertigo. Now that takes some time for those extra pieces of calcium to get absorbed and break down so that you have the original one there. So this could be, vertigo could be a self-limiting thing. It might only last like about a week until those extra pieces get absorbed. Why they come there, I'm not too sure. They could be coming from calcium from the bloodstream or calcium from the area there, and it kind of breaks off and enters there. But it will get absorbed back into your bloodstream. But now you have 10 pieces going around there, and that person's going to feel vertigo. Does that make sense? Okay? And we have medications that will, you don't have to go to the hospital. We could, we could cure this, basically take this medication. It'll deaden this a little bit. Can't drive, but deaden a little bit, and should go away in about a week's time or so. So do you understand the difference between vertigo and dizziness? Okay? All right, perforated eardrum, you can see it there. I think I showed that picture from before. Okay? There's another perforation over here. All right? Again, these pictures here are just FYI kind of thing. There's a healed one. See what that looks like.